It's really nice to see that you've all got real faces. I'm Lyman Ginger, Sharon Alcock, and there's lots of other famous tweeters in the room, including Claire RCGP, Ben Riley, Margaret McCartney over there, and I've also already spotted Mellow Johnny, who's down the front here, and Dr. John Cosgrove, who's just over there, and Richard Marr, and lots of other people. So thank you ever so much for joining us for this session. I think it's going to be lively. I'm going to ask you, if you have any questions, to tweet them. We're using 2 hashtags now. You may have seen the tweet earlier, because the RCGPAC hashtag is so busy that it was going to spin around so quickly that we've also started another hashtag, which is RCGPSoMe. So you can use either of those hashtags and I'll be able to see what you're saying. You'll also be able to stand up and go low-tech and ask a question on a microphone.
You won't see it if they just use the AC.
I won't see just the AC. I'm seeing RCGPSoMe, sorry. You can stand at any of the microphones, and I'm going to try and bring as many questions in as I can from the floor as we go through. So thank you very much. This came about because the RCGP and lots of other organisations have obviously realised the importance of a growing need for some guidance around how the profession uses social media. The first meeting of an RCGP-led multi-professional group on this started in March, and we just got to the stage where the social media highway code has been published in draft form. We're going to give you the link for that a little bit later on, and we'd really like you to download that and to give us your comments so that they can all be fed in to this draft, and eventually the RCGP will be ratifying it. Hopefully it will become policy. So, you know, your input is really, really important for that. I don't need to introduce some of the people here. Dr. Claire Gerarda in the middle there, who's chair of the Royal College of GPs. David Haslam introduced her yesterday as the Queen of Twitter, but I'm giving her a new title. She is the hashtag WAG, as far as I'm concerned. But Professor Susan Greenfield seems to think that she's causing an existential crisis. We're also joined by Dr. Margaret McCartney on the end there, who is the author of this book. She's going to be signing these books after us, just so you know. She's a GP in Glasgow here, and she also writes for Pulse and other media outlets. She's a blogger, and she's an avid user of social networks. She's also published in The Guardian today, an article related to this book. And Dr. Ben Riley here on my right is the RCGP's medical director for e-learning. He's steered the Highway Code project through calm and rough waters to this point, and I'm sure that there will be more. We're all on Twitter. You've probably seen our hashtag, our handles in the programme, so do tweet us here and now and thereafter. And whilst Claire's got her hands tied, someone is tweeting on behalf of the RCGP up at the back there, Greg. And so hopefully most of this will be able to be reflected live, and I'll try and keep my head not spinning in 6 different directions. But first of all, I want you to step away from your devices, 30 seconds. I want a show of hands. How many people in the room use Facebook? How many of the people in the room are on Twitter? LinkedIn? How many people blog? Going down the numbers, interestingly. Other SoMe sites? 1. Pardon? None of the above, okay. How many of you use it just professionally? Interesting, no one. How many use it just personally? More people. How many people combine the two in one handle? Interesting. Claire Gerarda, yes. Start with you. How does Twitter affect you? Do you think it's going to transform your job in healthcare?
I do, and before I start, I'd like just to say that there's a big movement to try and get Iona Heath on Twitter, so if we can, if we can crash the system. I think far from telecare, telehealth being the transformational part of healthcare, I think social media is actually what's going to transform our healthcare, and is actually already, I think, changing my relationship with patients. Not necessarily my patients, though I know some of my patients actually do communicate with me, and that's why I think some of the existing guidance that's out is very difficult, and I would say irrelevant, because it's who is my patient and who is somebody I'm just communicating. But I've already engaged, I mean, as one does, in real relationships with people where I am the doctor and they are not the doctor, where I think we become much more equal. But not equal in the sense that they're the doctor and they undermine my knowledge, but actually in an equal way that I can use my knowledge and they can use their position as an educated member of the public or as a patient to help me and to change my view. And I think it is something that is going to transform the way we work, and I think it is going to be something that we look back in 10 years and think, why were we ever scared about it, and why did we ever create rules so rigid, a bit like in our book here, in our document, we talked about the red flag, where people used to walk in front of a car with a red flag because they were so worried about the car. And so they had to warn people at walking pace. And I think we're going to look back and realise that we're at that stage now. So for me, it's a force for good.
We're going to go through some of the pros and cons, and I'll be interested in your views on those. Margaret McCartney, how does blogging and social media help in your work?
It decreases my stress levels, because if I feel really angry about something, I can go and blog about it, and then I feel better.
To discuss. Ben Riley, how many doctors are using social media? Have you got some statistics?
Yeah, well, as we just saw, obviously it's a self-selecting population here, but it's an awful lot. And in terms of society as a whole, it's increased a lot. I did look up some figures, and there was an Ofcom survey within the last year, I think, that showed that in the last 5 years, internet use in the UK has gone up from about 60% to 80% of the whole population. And of those, an increasing number are using social media. But among doctors specifically, the NPS did a survey, I think it was in the summer, and the people they surveyed reported 36% of them were using Facebook on a daily basis, and about 20% were using Twitter on a daily basis. So it's something that's really growing quite rapidly.
But should we be talking about this at all? Do doctors actually need rules for this?
Well, I wouldn't call them rules. In fact, we've gone out of our way, really, when we're writing this to make the point that we want to reinforce doctors' professionalism and see this as an expansion of professional practice and competence, I suppose. It's not the sort that a lot of the issues that crop up are so specific to the context that it would be impossible to make rules that were effective anyway, and that's not really the approach that we think would be helpful. One of the things that led to this coming about in the first place was, in fact, the first time I thought that we maybe needed to do some educational support for doctors on this was actually from the conference last year. A tweet that went out from a GP trainee, actually, and it said that the RCGP has just inspired me to join Twitter. And this is the first time I'm thinking, well, actually, if we're being responsible for lots of doctors signing up, we ought to actually also think about how we support doctors to use it sort of safely and get the best out of it, really.
Karen Price, who is Brookman Knight, is saying it reduces isolation, and I've seen international medical collaboration in real time on Twitter. That's one of the beauties, isn't it, really, that you can get access to doctors at all different levels of their career.
Well, yesterday, during Susan Greenfield's talk, I don't know how many of you were watching your handset and tweeting, but I was. And during the talk, so in real time, all over the world, people were getting engaged with what she was saying in real time. And we then began to trend on Twitter during the talk, which meant it was going round. And by the end of the talk, which was a fantastic talk, I learnt not just from her, but I also learnt from others that actually what she was saying wasn't evidence-based. There was a lot of things that she was saying that she couldn't back up, and people were sending hyperlinks, blogs. So it didn't detract from what I was watching or listening. It actually added to it and meant that I was even more informed. And I think that's where it's going to have an effect in education, and certainly an effect in what we do as doctors and how we conduct ourselves in conferences and educational spaces like this.
And carrying on from that, Ben Goldacre has blogged since then, yes, because of that discussion, hasn't he, in Bad Science about Susan Greenfield's talk. So
he blogged last year. He retweeted the blog, so he blogged in October 2011, I think. But it meant, and any of you that weren't following it, I think didn't have the same experience as those of us that were, which I think was a better experience.
Kerry Hood is saying, would you accept me randomising you to not use it for a bit to test? not quite sure that I understand that, but you probably do. There has been some research, little bits of research, looked at on how many doctors are using this for educational reasons, and obviously a lot of doctors are. And I think that one of the aspects that we're talking about is the doctor-to-doctor social media aspect, but then importantly there is the doctor-to-patient aspect. Do any of your patients ever come before you and say, I follow you on Twitter?
Quite a lot follow my blogs, and we do link to my blog on the practice website, more in a spirit of openness than anything else. But
Can you lean forward a bit so we can hear you more?
Sorry, so it's more in a spirit of openness, because I would hate to feel that I was somehow hiding something that I was doing. But it's actually really useful, I think, because it's all about information and about getting people quality information and about discussing the evidence behind statements that are made in the media or the press. So from that point of view, I find it really quite good fun.
But blogging is an information-giving exercise. However, Facebook and Twitter, for instance, are very much a relationship exercise.
No, I don't do Facebook, but you see Twitter...
If you did, would you accept, do you think, a patient as a friend?
Well, that's one of the reasons why I think I don't like it, whereas Twitter is all public, so it's all been done in public. There's no kind of private asides. I don't block anyone as a point of principle. So, so everything... I don't, just because I think, I am who I am, and that's what I'm saying, and if you don't like it, you can unfollow, it's fine, but just in terms of being open and straightforward and not covering yourself up, and I think in many ways it keeps you more accountable, because if you know that anyone can read anything that you write, then it's the kind of thing you have to be prepared to stand in Sauchiehall Street with a megaphone saying it, then it's okay to say it on Twitter.
Has anyone something? Yesterday, a patient tweeted me, because we'd sent out a letter to her son, inviting him for a tetanus vaccine, but we'd spelt tetanus wrong. I can imagine the embarrassment. So I was with my partner who was here yesterday, we rapidly got onto the practice, we've rapidly redone the letter. Now that's a patient communicating directly in a way, this is what I mean about changing. It's not that she's complaining, she's not doing it, and it's a very nice tweet saying, a joke sort of thing. So I don't mind. What I'm very careful of, because I know folk like the GMC are watching me, is I never give advice directly on Twitter, though I do give indirect medical advice, but not direct.
See, that is quite controversial, isn't it? Because you have to get that right. You've only got 140 characters. I know there's lots of talk about extending the patient, contact time, but 140 characters surely is going to the other extreme. Is that dangerous, Ben?
Well, I think there's a difference between signposting people to useful information and services and improving access, which I think is there's a real potential area to explore there, and using social media to do that, especially for certain groups, for example adolescents who might find it difficult to engage with services in the sort of traditional way, and this may be a way we can do that. A difference between that and providing personalised advice, in which is risky because you don't always have the full context of the records, the understanding of what's going on, and there is the risk. There's no means of checking the understanding at the other end very easily, certainly on things like Twitter. So I think it is perfectly possible for doctors to recognise that difference and use it in an appropriate way.
Where is Jamie Green? Jamie, you say that you've had patients, relatives try to add you on LinkedIn. Did you accept them? No. On what basis? Can you shout? Do you want to go to a microphone?
I'll shout.
Go on then.
Well, stand up if you shout.
Stand up.
It's better to go to the mic, actually, Jamie, because...
Well, easy behind the computer.
Comfort blanket.
Absolutely. No, I think it's probably inappropriate to befriend you and try to talk to you. Actually, in this specific case, the patient had died on the ward that I was working on.
Patient had died.
Her family added me and said, it's really good.
The BMA guidelines actually say that they don't recommend that doctors accept patients as friends, but that they do politely explain why it wouldn't be appropriate.
But how do you know that the patient, and that's what I'm saying, I think it will transform this medical, hierarchical, sometimes patronising thing that somehow patients have got a big label on them. We are all patients. Everyone in this room is a patient. Some of us may use the health service rather more than others. And I think this is how it's going to change things. So how do I know? I know one patient, because I recognised his name when he followed me. The rest, I haven't a clue. I've got 11,000 followers. How do I know which ones? I do know. We've just got to behave as if, my 3 advice in 140 characters is respect your profession, respect yourself and have fun.
Kerry Hood's saying that she likes the idea of patients being given this as an avenue to provide feedback. I don't know how many of you would agree on that, but as a journalist, a health journalist, not a doctor, I would probably argue that it's really important for you to hear what your patients are thinking. Perhaps sometimes painful, though, Margaret.
Twitter's not the right forum for that. I mean, if there's a problem that I'm not doing something right, or there's a problem, I want to know about it straight away, and I want to know who the person is. I want to be able to find out what went wrong, how to make it better. And I think it's fair enough for people to, if they thought I had done something terrible, to tell the world about it. But in terms of how to help that person best, I don't think it's going to be through Twitter.
However, that's where your audience, your client base are a lot of the time.
Or they're not clients, they're patients.
Okay, whatever you call them. If that's where they are. If they're unlikely to turn up in your surgery and tell you if they're unhappy with something, but they're more likely to put it on Facebook, isn't that where you should be?
Again, it's the whole idea. I mean, it's very much the thing about this doctors' rating sites online. It's the same kind of thing. If someone writes an anonymous comment that I don't know who it was or what happened, how can I look into that, sort it out, see if it was a reasonable complaint, if I'd done something wrong, where the problem was. It's not set up in a way that I think would make it easy. Certainly people can email in the practice, that's fine. They can write a letter, they can just say verbally, a carer or a friend could say if there was a problem. So I don't think we are lacking methods in doing it. But I think in terms of how to make healthcare better, I'm not sure with an anonymous rating or comment online is going to help me or the patient improve things, to be honest.
Can I just add to that? One of the points we had in feedback of the code, which was very useful insight, was around thinking about things like Twitter as a way to start a conversation, but it doesn't mean that you have to have the entire discussion in that way. And in fact, directing people into the appropriate channel is a useful skill to have. So, for example, if a patient did tweet something about, I wasn't very happy with how the consultation went this morning, the appropriate response might be to actually say, phone, we'll talk about this on the phone, or come into the surgery. So, it's not to have the discussion in public.
But at least it flags it up. If you do have questions that you want to ask on the microphones, please just go and stand at them, and then I'll bring you in. Number 4.
Hi, David Polking on GP in Rotherham, Luddite. Have I missed something here? There's a word that you're using called friend. I feel I've got a say in who my friends are, and that they're people that I have drinks with, I lower my barriers to, I go on holiday with, and share things with. You're talking about friends on something here, and I've got 11,000 friends. Excuse me, I have this problem sometimes, and my colleagues in the room, I suspect, might share it. You get someone phoning up and they'll say to the receptionist, yes, but the doctor's my friend. There has to be a boundary somewhere, surely, and I'd be interested to hear your views on that.
There's lots of... Can I answer that?
Yeah.
I have had... I once tweeted, why is it I like, when I meet my Twitter followers, I like them when I meet them in real life. And there is... I don't use Facebook, I don't even know what it is. I have had people round to dinner that I have only ever met through Twitter. Now, you'll think that's sad, don't you? There are people in this audience that I would now count as friends, true friends. Friends, I didn't know this lady before Twitter. I didn't know, hopefully, Johnny, you're a friend. There are people, so, and am I sad? Am I addling my brain?
Can I come in? I mean, I think it's about building communities with people who have shared values, and I think the health service is fragmenting around us. I think the NHS has been split up. We are being cast ashore, really, left to sort out patients with horrendously complex problems and becoming more and more isolated from each other as a profession. And to me, social media is a way of saying, actually, there are lots of doctors who share the same values, who would like to work together and who want to be friends and who want to communicate with each other. We don't have the luxury of working all in one big hospital where we can all get together for coffee on a Friday morning. But we do have this social network online where we can support each other, encourage each other, share what we're doing. One of the things I did on Radio 4 last week was about that magazine, What Doctors Don't Tell You. And I was feeling a bit, it was such a harrowing interview, really, with the woman. And then within 24 hours, someone had made these fantastic pastiches online of what car mechanics don't tell you and what physicists don't tell you. And it just cheered me up hugely, because I knew there were other people out there who thought exactly the same thing about how important evidence was and how to share that, and I wouldn't have that support, that buoyancy from other people if it wasn't for social media.
Pete Deverson is asking us to explain the basic differences between Facebook and Twitter, which we should do, actually. We shouldn't assume that everyone here is initiated. So Facebook really is how would you describe it? As a magazine, a personal magazine? Don't do it, Claire.
There's an analogy that was mentioned about Facebook is like your living room.
Oh, yes,
that
I like
you invite
that.
people in that, you sort of closer, whereas Twitter is like being in a sort
Yes.
of open marketplace and very much more public.
B.S. Stoltz, this is a quote from him, I like to say that Twitter is like a bar, Facebook is your living room, and LinkedIn is the local chamber of commerce. But they're all ways of interacting on your device, really, with people in real time. Facebook doesn't have a limit on it to a certain extent. You can put photographs on it, you can put text on it, you can use it very informally, or organisations use it formally. Twitter is just 140 characters at a time. It's live. LinkedIn is very much for professionals and people with common interests. Tends to be described as a networking site, a professional networking site.
I was just going to make one point. One difference between the two is that you have to make an active decision in Facebook to accept someone as a friend or not, whereas in Twitter they follow you and it's a passive thing on your part. You can't, you'd have to sort of go out your way to block them, which is obviously potentially could raise issues with your doctor-patient relationship more broadly. But one of the difficulties I think that this is flushing out is that human relationships don't work like that. We don't put people in little compartments and say, you're a friend, you're not a friend. It's a continuum of, and it changes fluidly over time. And I think that's where the difficulties come in, where you then, because of the way IT works, you end up have to set permissions, put them in a certain box. And that's, I think, where these issues are coming up.
I'm interested in if anyone has been able to use social media yet to improve patient involvement, because patient involvement obviously is the holy grail of the moment, isn't it? And so surely social media is part of the route for that.
There's two folk waiting at the mic.
Oh yeah, okay, perhaps they've got examples. Number 3, you were next, weren't you?
Hello, I'm Irene MacDonald and I'm actually Royal College Patient Partnership Group member.
Excellent.
And I exactly wanted to ask that question because it seems to me that patient participation groups can be very limited in their membership. And one of the reasons is people are asked to come to meetings. So there is that issue of how are you going to get the involvement, especially of young people, in practices' own groups. But also, I'm a lay member for PPE on my CCG. My God, the acronyms these days. And we're consulting, of course, about our strategies, what we're going to do. How do we get the voice of harder to reach people? What's the role of social media in these areas?
Do you want to answer that? Have there been any examples of good social media practice for patient involvement?
There's some very interesting examples where patients themselves have sort of taken the lead there, and there's one called Ninja Diabetic. I don't know if any of you are on Twitter. I understand it's a young person with diabetes who's basically set up, and I can't remember which organisation they're working. They're sort of supported by one of the charities, I think, or third sector organisations. But they're pretty much set up this group to support other young people with diabetes, and they discuss the sort of practical challenges that people face around, for example, if you're going in a restaurant and you've taken your insulin and they don't deliver your order, or you get dragged off by friends. What do you do? And you've got limited time. All these sorts of practical things that we don't always think about as doctors if you don't have that condition. And so that's an example where patients are, and I think she's got several thousands of people following her. And they're also, I am aware of examples where some NHS trusts are now using Facebook and Twitter to promote sexual health services to young people. I think NHS Rotherham is doing that as quite a groundbreaking way as well. So there's all sorts of interesting ideas. Obviously, this needs to be sort of evaluated, I suppose, and the sort of cautious side needs to kick in, but there's a lot of potential there.
And before I ever go, those of you who follow me will know that I quite often say I'm going to go on the radio today, tomorrow, on subject X. What do you think? And then I get loads and loads of responses about subject X, so infertility, deafness, or whatever it might be. And so actually there is a lot of interaction with people and the public and patients. Also, those of you who don't know Twitter, you can follow certain groups. So I follow mental health, and then under mental health you'll get all sorts of patient groups and single issue groups. So you can also target your own education if you like.
I agree. Yes.
People are saying, tips like don't say anything out there that you wouldn't shout out loud in the street. And there's, Erin Bury has a very famous quote who says, don't say anything online that you wouldn't want plastered on a billboard with your face on it. But probably everyone has fallen foul to a little bit of difficulty, perhaps if they've been on social media. I know both of you have, haven't you? Margaret, what's been your experience?
Yeah. Do you want any of the people written?
Yeah, we can go to them first if you want, actually. Number 4.
Martin Cunningham, GP in Belfast. I was thinking I might set up a Luddite group because I have similar feelings, but I work with a university practice, so I do have to be get involved with Facebook and the like. I'm old enough to have general practice when there wasn't a computer on my desk, when the computer was locked away in a cupboard. And then the next thing, they brought a computer into my room, and they told me that it would reduce my administration by at least 20 minutes every morning and every afternoon. It hasn't happened. It's totally increased the amount of time I have to spend on the computer as well as the paperwork. My concern is that am I going now to have to spend a lot of time addressing my patients on social networks as well, because I feel that I have plenty of work to be doing, and I'm just a bit scared that I will be expected to be online for a certain amount of time each day as well, which I think is just going to add to the straws on the back.
It is time-consuming.
If we get a bad flu epidemic this winter, I can guarantee you that we will use social media to help communicate. Because I don't know about you in Belfast, but when it came up, was it about 3 years ago? I can't even remember, time flies. When it was unbelievably busy, when we were getting hundreds and hundreds of calls, all saying the same thing, and I wished then that there was, I think Facebook was not quite, people didn't quite have it, so there wasn't a way of communicating en masse with folk, and I think that's where it will reduce our workload. It won't. You're not going to have to. You're not going to sit there and have to do a surgery. So I do say, and I've said it first, I will be the first GP to do a tweet deck GP surgery. All of you looking, not knowing what that is.
Have you done it yet? You've been saying that for a while.
I haven't done it because I'm a bit worried about it. I'm worried about the regulatory process. I do tweet deck on. Question answer. We do these. I think Doctors Net UK have done them where for people, that you might ask me questions. But I think to do one for patients, for the public, ask anything you want to ask about headaches, or anything you want to ask about chickenpox, or I really think that it's going to have a major impact. But I'm worried about the regulatory process at the moment.
And I think one of the things that doctor was intimating was that, there shouldn't be pressure on a doctor to do it as an individual. I mean, you managed to do it, but then you're queen of the thumbs.
But I remember my first tweet, and I remember why I got it, because the first real tweet I did of me, not of Claire at RCGP or Dr. General Practitti, which was my first name, because I didn't realise it stopped. So there you are. Was when I had my accident, and I was in casualty at St Thomas's. My husband was there with his computer, as one does, working, and I was waiting on the bed, waiting to go and have an X-ray, and I was in a lot of pain, but people were so kind to me, so I tweeted, I'm using the NHS and it works. And that's when I started really getting into it as me, as an individual.
Dr. Gandalf is pointing out that Twitter and Facebook is already supporting training in CPD. There's some references on there if you want to look them up. And Miles Mack is saying that his trust is already using Facebook for feedback from clients. Where is he? Do you want to come down to the mic and tell us about it in just a minute? That would be really good to hear about.
Somebody's asked for Pete Devison to stand up and show yourself.
Pete Devison, stand up, please. Be shamed. Hello, Pete Devison. Number 3.
Hello, I'm Jamal. I'm one of the GPST1s here in Glasgow. I just wanted to ask, we are not all tweet queens or kings here. I personally have about maybe 200 followers. So I feel like it's a bit of a self-declared kingdom. And I would like to ask, what would we be lacking? What would we be missing if we weren't really active activities or active Facebook followers? I mean, we're talking about the advantages, but what will I be losing if I wasn't as active as Dr. Claire on Twitter, for example? Would I be losing anything?
Margaret.
It's up to you. I mean, some people love it and some people don't like it and some people hate it. I mean, it depends what you want to use it for. I use it because I like feeling that I'm part of a community of doctors, and I like feeling that I'm part of a group of people, that I'm not just on my own, I'm not isolated, that there's lots of people who share the same concerns and worries about the NHS and, you know, are concerned about evidence. So, and I find that that buoys me, and it gives me lots of information. I get lots of information to write about. I get lots of good thinking done, interacting with people. I'm exposed to ideas that I wouldn't have been exposed otherwise, and I can speak directly to people. So if someone publishes a rubbish research study, you can tweet the journalist and you can tweet the perpetrator of the crime, really. And, well, I shouldn't have said that, should I?
I think that's something that we'll come back to, the interaction with journalists.
Anyway, but yeah, and then you can kind of come back to people and sort of say, actually, did you really mean that? Is that right? Is that wrong? And then you can get other people involved with sort of picking apart evidence. So from my point of view, I take great pleasure in doing that, but I can see why other people would just find that utterly boring.
Number 4.
As a Podiki GP, my tweets seem to have to go to New Zealand and then come back again in order to appear on that screen. They seem to disappear. But my Richie Roberts, who's the president of Wonka, talks about his patients having his mobile phone number, all of his patients having his email address, so that he can maintain that personal relationship with them wherever he is in the world. He talks about a colleague who does this at home for her patients, and how that results in a decrease in the ambulatory hospital admissions, or the accessible in hospital admissions for her patients, because she's there for them in a real-time basis, in a real way, which, you know, I'm not hearing, and I certainly don't expect that tweet decks are going to achieve that level of personal interaction and personal support for our patients. I would challenge you all, Queen of Tweets, hashtag WAG, I'm thinking about doing this myself. Providing all of your patients with your mobile number and all of your patients with your email address, so that you enhance the personal consultation, the personal communication, the personal relationship that you have with them using these media in a real way.
I do already. I give my patients.
All of them?
Not all. I'm right. I basically work in 3 areas at the moment. One is I look after sick doctors, so I have about 900 addicted and mentally ill doctors. They all have my email address and they all have my phone number. Not all, but many of them. I also look after a population in Tower Hamlets, which 90% are Bengali. I don't give them my email or my phone unless exceptional circumstances for various reasons. One is the serious language issue. And I look after substance misusers, patients on methadone, and I've got about 50 to 100 of those, and they all have my phone number. And in fact, if you look to my phone, I have to sometimes give them anonymous names, because if the phone gets lost, I don't want them, you know. And you'll see, Claire, I'm running out, can I come and see you? Claire, when I'm monitoring his weight. So, yeah, I think it's fantastic. They also tweet me, but the tweet is different because, as I said, I worry about the regulatory process.
What's your name, Doctor? Sorry.
Joe, Scott Jones.
Okay.
I think that, that's a really interesting story, and something that, you know, perhaps be interesting to hear from the floor, how people feel about providing that personal relationship with their patients on a real-time, long-term, 24-hour, 365-day-a-year basis.
And it's
asking a lot of doctors, though, isn't it?
It's very rarely abused, and when it is abused, I take it seriously because I think then they're ill. And by abuse, I even mean sending texts in the middle of the night, sending texts at weekend. I think that is abuse, you know. So, but I take it seriously because unless they're calling for help, because then I think what's going on, and it's incredibly rare, but in the old days, you used to give your patients your home phone number. Don't you remember, older GPs, when you were doing palliative care, looking after elderly patients who you were worried about?
But then we were reporting doctor burnout.
Yeah, we're reporting more doctor burnout
That was
now.
before the European guidelines came in to protect doctors from working around the clock. It's interesting, isn't it? Let's have a show of hands. How many people...
I'll just say that people don't abuse personal relationships.
No. And when they do, I think it's because they're ill. There's something not right. That's
how many people in the room think it would be a good idea to give their patients their email address or even their mobile telephone number for those occasions? Okay, how many people think it would be a very bad idea? And I'm going to give you the choice to say I'm not decided. So how many people think it would be a bad idea? More. How many people are not sure? Okay.
Can I just say something? I think most GPs actually would genuinely love to do more personal contact and more continuity of care, but the problem we have just now is the rubbish GP contract that just forces us into doing stupid things all the time, ticking boxes that are just inane, doing questionnaires that are just non-evidence-based and ridiculous.
She's lovely.
But you know... if we actually got rid of all the crap, we actually could provide a much better service to our patients. So paradoxically, this contract, this counting, this bean nonsense, silly, ridiculous thing we've got ourselves into, it's actually created as having less time and less opportunity to give to our patients. And I think, you know, if we went back to basics and said, actually, patients don't abuse those personal relationships, this is what the heart and the core of general practice is, and actually say we don't need the contract to be doing that, we need our professionalism to shine through, because that's what we have. That we came to this job with a vocation, and we're somehow being diverted from what we really want to do. And I think we should go back and say, yes, we do need to get back to that personal relationship, but in order to do that, we have to get rid of the crap that's stopping us from doing that.
Number 4, do you want to tell us what your trust is doing?
Yeah, I'm at Miles Mack, and the first thing I would say is how fantastic it is to be in the same room as so many people I'm following on Twitter.
Tweet up.
I'm from the north of Scotland, and Regmore Hospital is our sort of basic general hospital, and as the new area medical committee chair, I went to see them to discuss some of the issues that we have as far as outpatient times, waiting times to get letters back, and all the sort of things that bother us so often as GPs, and I'm sure it chimes with many of us in the audience. I was hugely impressed by the charge nurse Murray Fraser, who's instituted a customer care program. They've looked at what their individual values are as far as what they aim to achieve for their patients, and they then compare that to the feedback they're getting from the patients to see what changes need to be made. It's amazing some of the things they've come up with, simple things about medical students introducing themselves and actually getting consent for them to sit in, about registrars interrupting clinics. And the moment of truth for me was actually when we agreed that actually GPs should be considered as customers too, either because we are direct the work we do with them, but also as advocates for our patients. And they're beginning to start to use what they're really craving is real-time feedback on what's going on. I think this is crucial, and they're beginning to start to investigate the idea of using Twitter and Facebook to do that.
So you would say that it has been empowering for the health professionals to hear that feedback and to act on it quickly?
They're actively encouraging that as part of the customer care program, and it's hard to argue against that, particularly when it's on the basis of what their personal values are and the benefits to them of actually stating what their values are as a team and actually seeing whether they're achieving that by matching it to the feedback from the patients seems to be a beacon of excellence. And the thing that I'm particularly impressed is it's happening as a bottom-up basis. There's no reason why any outpatient in any hospital couldn't do that. And it may be by using Twitter, I'm hoping that they'll be able to spread the word and spread good practice rather than being seen as a top-down imposed solution, which, as Trish Greenhalgh said in a BJGP article, is potentially going to fail.
Seems like a really good example. Number 3.
Hi, I'm Solomon Begg. I'm a GP in London. Question for Claire. How do you, when you're giving somebody...
Can you speak up a bit? We can't quite hear you.
So when you're giving somebody your mobile number or the contact information, what ground rules do you explain to them? Do you say to them?
The ground rules are the email. So email, I say, it's not secure, even NHSNet. It may get lost, and I may not read it. And if I respond, you may not have confidential you may not have a confidential service because I don't know who's reading your email. So those are the 4 ground rules for email. For telephone, nothing really. I mean, I say I prefer you to text. I say I don't work all the time. I say I may in the evening have had a drink, which means I can't respond clinically. And if I'm not, and never use it as an emergency because I may not be there. And that's it. And I promise you I've done this for 15 years. I mean, not email as well for about 15 years.
Can I was just going to add to that. The whole area around doing this sort of by email and confidentiality you mentioned is interesting when we relate it to social media, because there seems to be a bit of a generational shift going on around people's views on privacy and looking at things that younger people who have grown up with this sort of world, the information they're prepared to share online is very different, I think, to what other people might consider appropriate. And it sort of raises interesting questions about to what extent do patients have the rights to not be private, I suppose, or to say, actually, I don't mind asking you for information in public, I don't mind if other people know. In some ways, I was thinking analogy is a bit like the people that come up to you in the supermarket or the petrol station that, you know, when you're doing something else and just say, oh, doctor, can I just ask you about my rash and, you know, and how you manage that. And whereas I think, you know, teenagers wouldn't think of doing that, but they would quite commonly, you know, they might go on a TV show and, you know, bear everything, or they might, you know, ask you publicly for advice on sexual health. Is an area you think that you wouldn't necessarily be first sort of to want to ask advice for publicly, but it seems to be working quite well on Facebook.
Do we know what the breakdown is for social media between men and women as well? Because that's a real issue, isn't it? I mean, men's health information, if there are more men on Twitter, do we know, or on Facebook?
I don't know.
It'd be interesting to look at that.
Computer games.
If it's a way to get it to men.
There was one survey I saw with Facebook actually suggesting that there was more women using Facebook than men actually. I don't know about Twitter though.
Okay, number 3, please.
I think you're on number 4.
Hello, Alison Douglas. I'm a GP in Buckie in the northeast of Scotland. On a couple of levels, I'm really interested and excited about the debate today, particularly the doctor-to-doctor communication. Increasingly, we spend an awful lot of time in our rooms working long days and not really seeing our colleagues. And also the way practices and other organisations are using Twitter to get feedback. But I'm deeply concerned about the direct patient communication via text, phone and email. I was brought up, and I teach the learners in our practice, to always document your professional communications. Not just to be defensive, but to be professional, so that you record what your advice is and what your findings are. And I'd like to ask the panel how they square that with what they're doing.
You document it. There's a read code called email. There's a read code called text. The problem is I still haven't worked out how to send a text to a document, so I have to verbatim write it, but you can document. I think I'm different. I was brought up when the surgery was our front room. When my father was a GP, it was our front room. And as a child, I would peer over the banister and see patients. I was brought up that you were part of the community. I was brought up that that's what being a GP was. And when I became a GP in what was then inner city London, and it's become a bit gentrified now, I lived what I call in my parish. I lived 100 yards away from my practice. I trained 100 yards away from my home. And the patients, there was no distinction between patients, friends, and others. I was the community. These people, my children went to school with. I just had to learn to split my brain so that I never talked about professional issues at all with my family. So if I saw someone and I knew that their child wasn't theirs, it just became a split brain that was so boundaried. But it didn't mean that I wasn't accessible. So I was brought up differently. I wouldn't say to the young ones, if you don't like it, don't do it. In fact, the young ones don't live in their parish anymore, so it's very different. But I think we shouldn't be scared of it, really.
And in fact, just to add, I think, if anything, the documentation for this is actually higher than it would be for a phone call, for example. And in fact, this is often an area of problem where doctors can get into difficulties later on. There is that issue about everything you say being documented, but also particularly in the area of doctors interacting with other doctors and the issues that have arisen there where There have been, high-profile cases occasionally where doctors have fallen out with each other sort of publicly, and that all being sort of documented in the public can be pulled back as evidence a long time afterwards. It's something just to consider.
I think we'll need to talk in just a second about that, everything being kept and the kind of some of the downfalls, but I just want to get through these people's questions. Number one.
Thank you. Can I give a perspective from Bangladesh, where I work and live using this? My name's David Gaskell. I work as the medical advisor for Asia for the Foreign Office. I spent the last 5-6 years in Bangladesh, and at a public health level they're using social media to deliver messages across 168 million people, across various networks, primarily to mothers. They've used media, for example, to promote rotavirus infection vaccine, to try and lessen impact and drowning with mums and babies with ponds. There's a dengue epidemic going on just now, so we're trying to deliver the message to avoid mosquito bites just now. So it's working really well by getting into Airtel and Grameen networks. Good. And people take it on. Then within my organisation we use social media for things like consular messages to promote the right healthcare advice. And personally, I found I've been getting out of touch with my university and teenage kids at school because they just don't answer email and phones anymore, and they're all using Facebook. So a friend said, I've got to learn about Facebook, which I've done. And I know it sounds a bit sad, but the most frequent, because I travel across a lot of Asia, and the best way I'm keeping up with my teenagers and my university kids is Facebook.
So you're a convert?
I'm reluctant, but it is the means to communicate with the young.
I mean, it's a specific value to those kind of geographical scales, isn't there? And also for rural areas. Someone mentioned rural areas on Twitter earlier.
Miles mentioned,
surely there's got to be a value for hard-to-reach geographical areas as well as hard-to-reach groups.
Yeah, and also a lot of the concerns we have on litigation and so on, it just doesn't exist. We're not, I totally agree about backing up good information. I'm sure we're all we agree with that, but issues that we struggle with here aren't issues for a lot of the poor in the world where social media is making a big impact.
Okay, I'm going to take a 3 and a 4 and then we'll answer both of them together.
Hi, Joana Neto from Portugal. Just to give you a clinical case we have recently published about a Facebook house call. Something like that. It was about a teenager that her mother was quite worried because she was acting differently and trying to be not going out with her friends. Well, she has changed. So the trainee went to her Facebook and saw her history because she was very active. She used to publish a lot of things, and from a sudden there was absolutely nothing. So it was able to talk to her, to ask her to come or us to go at her house. And well, she did have a depression, so she was treated. But the Facebook was the link, because the mother is very worried. And if it wasn't by Facebook, we wouldn't have been able to reach her. And we do, in Portugal, several health units do use Facebook to give messages to patients and to do some educational programs through the page.
Thank you. Sounds excellent. Thank you.